Namaste. Psychoanalytic psychotherapists, especially those young in the profession, have a multitude of questions. To address these questions for the greater good, we have crafted a series titled Questions of a Therapist. Our journey begins today with some important questions in area of transference, stalemate, self-revelation, and so on. If you as a therapist have questions, please feel free to send them to us. If we can, we will surely address them. Our expert in this journey is psychoanalysis consultant, Mr. Himanshu Vaidya. Namaste.
Namaste.
So can we start with the phenomena of transference? How to identify transference and counter transference?
You can go by two categories of indicators. There are external identifiers and there are internal identifiers. External identifiers can be the patient literally says that I feel as if you are my mother or you are my father. It's a literal statement by the patient, which tells you that at an unconscious level and partly at a conscious level also, the transference is taking place. And he has started seeing you as a parent figure. Second external indicator can be his behavior. He may not literally say that I see you as a parent, but his behavior says so. Like he would come and say, I had a fight with him and I really abused him. And you ask him, what did you say? And he says, no, I can't say it in front of you. And if you ask him, who are the people in front of whom you cannot say this? And he would probably say, my parents, teachers, my elders, and you. It's an indirect way of saying that you are in the same galaxy of parental authority figures. Or after doing something which provokes guilt, he can come to you for approval. And often he can request for a special session and tell you that X happened. And that is because X led to provocation of guilt, and he wants some parent figure to listen to it and not punish him. He can't contain it within himself. He has to share it with a parent figure, which tells you that at a transferential level, he is talking to his parent, but his good parent who will not punish him, listen to him and accept him and pardon him, at times even support him, at times contain him, all the anxiety of guilt that is there. Or he may behave in a way which in certain cultural contexts is unique. Like he has a birthday, he comes to the session, he touches your feet. Now that is very Indian. It's very Hindu in culture. So this phenomena, non-Hindu therapists may not see. But if you are practicing in India, it's very much a part of the Hindu culture. And you may see it very often, where he sees you as ideal parent. So these can be external indicators. Then there are internal indicators, which is the counter transference. That the transference will solicit counter transference, and you will start feeling in response to his transference certain counter transferential things. And usually transferences are positive, far more positive than negative. So on the positive side, you may start having erotic dreams related to the parent, related to the patient. And when you have an erotic fantasy related to the patient, it tells us that if you as a person naturally don't have those fantasies, but those fantasies come and go, usually in the presence of the patient, then that is a counter transference to his unconscious transference of erotic desires towards you. Often, if you feel yourself getting specially ready for a patient, that before a session, you go before the mirror and you spend unusually more time, or you are unusually more soft and delicate with one patient, then those counter transferences may be at work. And this is a very powerful force. A therapist can easily fall in love with a patient out of counter transference. And this has happened in case of many therapists. Jung was one famous therapist, where the counter transferential responses could not be controlled. Freud, that way, was a very strict controller of himself. He never slipped, but many others did. So we have to be very careful about the responses we have towards the patients, especially erotic ones. And in fact, it has to be seen positively that in the session, if out of nowhere you have a erotic fantasy towards the patient, it means the patient is having erotic fantasy towards you, and it's a counter transference to that. And we have to be capable enough to look at it in a detached way and see it as a positive sign that the patient feels safe enough to undertake the transference. That in the unconscious of the patient, you are taking the place of the romantically, erotically desirable. So this is the way to identify, and there are different ways of addressing it. Like the patient comes and says, I cannot say this to you. I cannot tell this about this event to you. And you can bring it to his notice. You talk to me as though you are talking to your father. And he says, yes, that's how I feel like. But we both realize that I am not your father. So this intervention brings in the reality into the situation and breaks the transference for a moment. Similarly,
so the ideally transference should be interrupted, or isn't it at times a desired replacement, or in fact the displacement from the object of desire of the real life in the therapy room?
it's a very good question. I did not want to go into details of transference because it is a wide area and I would need a 2-day workshop to only deal with transference.
Right, sir.
Someday when we have adequate interested participants, we can do that workshop. But to address in brief the question you have raised, it's a very good question. Should all transferences be addressed? It's a very important question. And the answer is no. Like if you are sitting in a session, everything is going fine, and suddenly there is an erotic fantasy related to the patient. And you know it's a transference from him and it's a counter transference from you. Now it's a completely unconscious movement. The patient does not know. Unconsciously, he has erotic desire for you and he has put it into you, and you have responded to it by creating a fantasy in your mind. It's a completely unconscious operation. You have become conscious because of your knowledge and because of your own analysis. And that is where your own analysis is very important, so that you don't confuse between your fantasy and the counter transference fantasy. Only when you have been thoroughly analyzed and you know what is your material, what are your likings and dislikes, you can very clearly say that this fantasy is mine and this fantasy is not mine. And when you are very clear about this fantasy is not mine, then you can label that as a counter-transferential thing. Now, you are clear about it, the patient is not clear about it. The question is, do you address it or do you let it pass? In most cases in India, we would have to let it pass for a variety of reasons. Some patients might take offense to this being interpreted. They may not be able to accept the truth of their own unconscious, and they may think in defensive reaction that you are a pervert or you have a erotic agenda, or many of them may not feel safe with you anymore and stop coming or stop revealing certain things. So this is a very good example of where you would let a transference pass without addressing it. And there are certain transferences in the practical situation we may have to just pass forever. Why I'm saying so? Because if you are into training analysis, somebody is getting trained as a therapist and he's in training analysis, you can address every transference and discuss it. But if you are not in that situation and you are in a situation where the patient is not therapy mature, if the patient is therapy mature and the patient is into long-term therapy, you can again interpret such difficult to interpret transferences. But in most situations, practically speaking, we don't have that context. So many of the transferences we just allow to go unaddressed, making a note of it and understanding what is happening, using it from our angle, but silently. Not bringing it up in explicit discussion. You may use it for technique, for formulation, for therapy, without discussing it with the patient. You may discuss it with the supervisor and find out what best to do about it, but you don't discuss with the patient. If the patient is therapy mature, into long-term therapy, ready to take it, you can address transference. Certain transferences you may postpone for addressing. That somebody comes to you in the first or second session and this kind of transference happens, the erotic transference, and you feel it's not safe, it's too early, you can postpone it. You can bring that in once you cross 50 sessions, 75 sessions. So it's not a now or never situation. Certain transferences can be interpreted right at that moment. Certain can be postponed. Certain may not be interpreted in short-term therapy or moderate-term therapy, or in therapy of very fragile patients from a particular standpoint related to that transference. So this is how we look at the interpretation of transference. Another important aspect of interpreting transference is, can the patient take it? The capacity part. So there is a morality part, the part of morality and acceptance on moral grounds. And there is a capacity part. That there are certain transferences, say for example, a narcissistic has some kind of transference on you, and he is experiencing his narcissism, omnipotence through you. And if you bring it in discussion and you just break it into pieces, that man is hanging from a rope and you are cutting the rope. So the sheer emotional capacity may not be there in a fragile narcissist to accept that interpretation. So in case of such omnipotent transparencies of fragile narcissists, we may just have to let it be as it is and not address it. So it takes quite some judgment what to address right then, what to postpone, and what to never address.
So another aspect, a small question again with the same topic. Is it that all transferences have counter transferences? One. If yes, then can it be just awareness of the therapist and then dealing with it, or it is mandatory to have a counter transference?
It's a good question and a theoretical question at one level and experiential at another. Conceptually speaking, usually we believe that there is a counter transference in response to every transference. But in many cases of counter transference, we don't recognize the counter transference in us. So the process happens, but we are not capable of identifying because it happens either unconsciously, or it is too feeble, or it is defended against or pushed aside, or we are busy somewhere else and we are not able to recognize a counter transference. That is a conceptual position. But there is a second conceptual position that weak transferences may not be able to solicit a counter transference. And counter transferences also are based upon the strength of the transference and the characteristics of the therapist or any person on whom the transference is put.
Right.
So based upon these two, whether a counter transference will arise or not arise, that is one. Second, if it arises, will it rise to awareness or not? So if it does not rise to awareness, it would be there in the unconscious but never come to the consciousness of the person.
Right.
Secondly, I will not go deeper of this part, but there is something which is called delayed counter transference. That it may happen after the session, not necessarily at the moment. And I'll just make a mention of it without explaining it. Often, not often, but I would say almost always, therapy ends, but the transference does not end. And similarly, therapy ends, but the counter transference does not end. So therapy may have ended 2 years back, but the counter transference from the therapist side still may be there. And similarly, the transference may still be there, although you're not seeing him anymore. He may be in a different state altogether. One of my teachers told me this, very important. He was in analysis for, I think, 7 years.
Mm-hmm.
I think 4 days a week, 3 or 4 days a week, 7 years. The classical psychoanalytic analysis. His analysis got completed. 5 years went by. His therapist died.
Oh.
But even after his therapist died, the Facebook of the therapist was still there. And my teacher would still often open his page to find out what is happening in his life.
Oh.
So the therapy has ended 10 years back, 12 years back, but the transferences are still on. That person is no longer any other ordinary person. He is still loaded with transferences. So years after therapy is over, transferences may still be active, and counter transferences may also still be active.
Very interesting. We move on to our next question, sir. It relates to encountering the same issues in life of the client and that of our own life. So how are we, as therapists, we're supposed to have an understanding to this phenomenon?
It's a very important question and a very truthful question in life of every therapist. If you see enough number of patients, it is inevitable you will come across somebody who has problems which you once had, or presently you have, or in future you are likely to have. And this creates dilemmas for the therapist. Take situation 1. The patient brings to you a problem which you had in the past and you solved successfully. There is a temptation to offer him the solution. So we have to tell ourselves he is not us. His situation is not our situation. So we bring in our wisdom of experience into discussion without being prescriptive. So when he says, I have this problem, so we say, let us go over it from a multitude of perspectives and see what comes up in our discussion. How would you like to reflect upon it? And he says 2 or 3 things, and then we can bring it in and say, one possible more way of reflecting on it can be this. How do you feel about it? And you give your wisdom, and then he reflects upon it, and he tells you whether any situation works or does not work. So this is one part, that we share wisdom without being prescriptive and without self-revealing that this is a problem I have been through. And this is how I solved, because then it uses your authority as a therapist. You are using this omnipotent transference onto you. And we don't give solutions, we help people arrive at their solutions. So we are facilitators, we are not prescription givers. We help the person on his own self-discovery. So this is one situation. Second situation is, he has a problem and you also have the same problem in your life at present. It's active. The temptation there is to become a friend and start discussing and give up your stance as a therapist, which we have to avoid. We have to control ourselves. Two situations come up in this regard. One, we give him a very reasonable direction, of course through a process of open discovery, not in a prescriptive way, but we help him arrive at a very reasonable position. And we are not able to implement the same reasonable position in our own life. And it creates a sense of guilt and hypocrisy in us, that what I am helping others to solve, why am I not able to solve it myself? Why are my blessings for others and not for myself? So two things happen here. One, it provides us with resolve to be resolute and implement the right thing in our lives. And we thank the patient that because of him, that resolution could happen. Otherwise, we did not have the strength to really do the right thing in our life. and the patient is healing us here, unknown to him. There is a very good research paper on this that it's titled "The Patient as a Therapist to the Therapist."
Very interesting topic.
When we do therapy, a lot of our own things get healed. So it is not only in our own therapy or in our own supervision, in our work as a therapist also often we get healed. Because what was in the background of our mind, something very hazy, is now in front of us very vivid, and we cannot escape it. And what we did not have the courage to be clear about, our discussion with the client has put us into a situation where now we have the courage or the imperative to see in clarity our own situation and remedy it. Third situation can be, both of you have the same problem and he is handling it better than you. So first, there is anger at oneself, a feeling of inferiority and shame, that who is treating whom. And then there is an attack of envy. And if we are passed through these two areas, then there is a genuine appreciation and gratitude that you have shown me a better way than I could show myself. And thank you for that. We may not be able to say it in therapy, but we can bless him in our heart that you showed me a better way than I could show myself. And putting aside our envy and our ego, we accept a better solution as a better solution. But we have to be past the first two phenomena of inferiority, shame, anger, and attack of envy. And if we have a narcissistic core, then narcissistic rage.
Not to forget.
Yeah, not to forget. At least I can't forget.
The
The third is something likely to come up. That he is going through something which is likely to come up for you in future.
Okay.
And we have to be careful that we don't turn the discussion in our favor. We remember it is his session, not our session. And if we want to discuss, the right place is our own therapist or supervisor. And if we don't have either, and if we cannot have either, then our colleagues, if there is anyone we trust enough. But this is not the place. I mean, we can't hijack his session to solve our problem. So we have to be sure that unconsciously we don't steer the session towards a discussion which is more for us and less for him. So these are some of the issues which come up, and over a period of time we realize that these issues are inevitable and it heals us without any doubt, and we become better problem solvers for ourselves and others. And the patient acts as a mirror where we see those parts of ourselves which without him we refuse to see.
So the technology has done and served us so well that now the usual couch, the therapy couch, has converted into the screens. And there comes the dilemma of encountering, the young therapists are encountering different cultures, different nationalities, patients. So the beliefs related to gender, culture, religion, what stance we take on them?
It's a very important question in a globalizing, technology-enabled world. Simple answer is we keep our own beliefs outside the therapy room when we enter in. And we enter the world of the patient as he sees it, not as we see it or as it ought to be. So we leave our beliefs outside. One. Second, religion especially has to be picked out of this whole collection, because it can be a very controversial thing to address. And everyone may not be open and mature enough to endure a open, truthful discussion on religion. And often it goes true for politics. So in such cases, we have to be very clear that will a discussion on this help the patient heal himself? Is it necessary or not necessary? If not necessary, just avoid it. If necessary, then take the permission of the patient. That you can tell him, okay, one of the things you said is belief X, which is religious in nature. And would you like to discuss it? Would you be comfortable discussing this belief from multiple standpoints? Or would you like to continue as a faith that you have and not question it? Whatever choice you make, we go ahead with that. So if somebody says that it's a religious belief and it cannot be questioned, we let it be. The idea there is that whatever is there pathological will come up in some different way, in some different context, and will get addressed in some way. Say, for example, there is a trait of rigidly believing in something and hanging by it like a rope. It will come in different contexts, and you can point it out that in many areas of life, you have a belief and you are terrified of questioning that belief. So if you believe actor X is good or footballer Y is good, and if anyone questions, you react so violently as though you are hanging by a rope and this belief is a rope, and if you let go of the belief, you will fall into a valley. Because we see it in your belief related to cricket, related to football, related to politics, and we also saw once related to religion. So the context is secondary, but this core psychological fact is primary. So can we keep the context out and go into this core primary fact, that why is it so necessary for you to hang by one belief and then defend that belief to death and not be open to any discussion about that? So it would come up in some way. Now, there is another element to it which is slightly larger, which is a social systems issue. Say somebody comes to you and he says, I have depression, anxiety, and I am also a homosexual. Now, would you count homosexuality as one of the problems to be discussed, or would you say it is not a problem at all? And this is true of the entire gender area. USA, Germany, UK, Canada, to some extent New Zealand, they have become so gender fanatic that the therapist is not allowed even to discuss the possibility that the gender you believe in may have something pathological about it. I think this kind of censorship in the therapy room, even Stalin would not impose, which the so-called liberals have imposed. They are hardly liberals, they are actually worse than Stalin.
Exactly.
So the question there is, if you were to answer this question in 3 different time periods, what is right would be different. Let us say the same patient had come to you in 1950. At that time, homosexuality was considered to be a psychological disorder. So you would tell him you have depression, you have anxiety, and you have homosexuality. We have 3 problems to be solved. If he comes to you today, homosexuality, psychiatry says, is no longer a disorder. So DSM has changed. And this tells us that psychiatry and DSM are not scientifically driven. They are half scientifically driven and half culturally driven.
Right.
So we are not dealing with pure science. We are dealing with half science and half social science. So there is nothing strictly scientific about either DSM or psychiatry. This brings us to a question. If such a person comes today, DSM does not say homosexuality is a disorder, but psychoanalytically speaking, homosexuality may be because of 2 reasons. It may be natural or it may be a defensive action. If it is a defensive action, then definitely it's a disorder and a pathology to be solved. After solving the pathological reasons behind the homosexuality, you leave the person with an open choice. He can continue to be a homosexual out of choice, but without being driven by a pathology. You can do the same choice without being driven by a pathology, and you can do the same choice driven by a pathology. And it is incumbent upon psychoanalysis that it frees the person from the pressure of pathology.
Absolutely.
So if you go by this, which is a real holistic way of going about it and not taking to any extreme, we can say that we have a problem of depression and anxiety to solve, and we'll work on it. And you also say you have homosexuality. So do you think that it is a problem to be solved? Or would you like to examine if it is natural or it is coming out of some trauma? And after that examination, you can decide for yourself whatever is convenient, best suited to you. That free choice is absolutely free. But would you like to reflect deeply upon this orientation? If you say yes, we can go deeper. If you say this is natural and I don't want to examine it, we don't examine it. But